This is a third video where we'll be looking at SLE, and just a brief crash course. SLE stands for systemic lupus erythematosus, and the good way to think about this condition is you have the body mounting and launching an attack onto the body. So there are various environmental factors and certain genetic factors that led to this presentation. Check out the two previous videos, but a brief crash course is that we were seeing that some sort of trigger led to a massive apoptosis, and we had antigen presenting cells presenting these antigens to T cells, and T cells were then stimulating other cells. Ultimately, it led to the formation of antibodies, anti-nuclear antibodies. So these antibodies that were being formed were against the body's own nuclear material. Now, the body has got various mechanisms to ensure that this that's been formed does not go and launch an attack onto itself. But in SLE, there are various things. For instance, the human leukocyte antigen DR2 and 3 is distorted. So because this is distorted plus a reduced amount of complements, it meant that the body can then mount and launch an attack onto itself. So we looked at the clinical features and presentation of these patients. In this video, I want to look at the investigations and the treatment of these patients. Okay, so starting with the investigations of a patient who presents with SLE, the thing to note about this condition is that you have diagnostic investigations, you will have supportive investigations. So let's start with the diagnostic investigations. So a patient comes to you with SLE and you want to be sure, you want to diagnose it outside of the clinical features that you've already thought of pointing towards SLE. A good way to diagnose it is, remember in SLE, we've just been talking about these anti-nuclear antibodies that the body has produced. So the first investigation to diagnose this condition will just be that you are checking for anti-nuclear antibodies, or ANA. Now, the thing about ANA is that it is highly sensitive. However, despite it being sensitive, it isn't really specific. This means that whilst ANA can come out positive in SLE, SLE isn't the only condition that will have ANA positive. You would have other conditions like rheumatoid arthritis, scleroderma, all giving you a positive ANA. So ANA should always be the first investigation that you're going to do. You try to check out for anti-nuclear antibodies. Just to emphasize, it's not specific. It's highly sensitive, but it is not specific. So you only move on to the next other diagnostic investigations if ANA is positive. So ANA, anti-nuclear antibodies, if it's positive, we can then go to these other investigations. So we had the cell, and it's got its genetic material, massive apoptosis happened, and we had this genetic material being expressed extracellularly. So one of these things that's being expressed is the genetic material itself. And if you think about DNA, remember that DNA is just some helix structure. It's a double helix structure. So what if we could investigate for this? And that's where our second investigation comes from, which is anti-double-stranded DNA. So anti-double-stranded DNA is more specific for SLE. And again, remember that this DNA, which is then being expressed extracellularly, in the cells, it's wrapped around these proteins. These proteins are known as histones. So we can also check for that. And this is where the third investigation is coming in, which is anti-Smith, or SM. So the diagnostic investigations ideally that we are interested in, you start with ANA. If ANA is positive, we can then go on to anti-double-stranded DNA, and we can also check for anti-Smith. So these are a little bit more, these two are more sensitive, more specific for SLE. Of course, there are other investigations like anti-Rho and so forth, but for now, just remember, start with ANA. If ANA is positive, you can go to anti-double-stranded DNA, you can go to anti-Smith. Any other investigation you can think of will then be just supportive. Another thing we mentioned in SLE is that there is reduced amount of complements. So you can just check for the serum complements. Then from there, you can just think of any other system that was affected. These patients were prone to getting lupus nephritis. You can investigate by that through kidney function tests. You can do massive urinalysis, including microscopy, culture, and sensitivity for the level of the kidney. Remember that they are prone to have anemia, so a full blood count and differential count is something that's important. SLE can affect the heart, so remember that it can lead to pancreatitis. So an ECG and echo are good things that can be done. And just in case of certain things like antiphospholipid syndrome at the level of the heart, you can also just check for cardiac enzymes if it's necessary in that particular case. A chest x-ray also would help out. So just think about the different systems that are being affected by SLE, and you can investigate for that. But all in all, remember that you are starting with your diagnostic. ANA. When ANA is positive, you can then move on to the others. In the treatment, this is a condition which is initiated by triggers. So the first thing you want to do is patient education. You want to ensure that these patients are educated on triggers, things that are influencing all these events. So you inform them on the triggers and how they can avoid them. Things like to prevent UV radiation, things like sunscreen, and things like wearing long-sleeved clothing, hats, just to prevent that exposure from UV radiation. Okay, now coming into the inflammatory processes, a good drug to start on is hydroxychloroquine, the same anti-malarial drug. This is going to help reduce all this cascade of events. Another drug to remember will be prednisolone. However, this is a steroid, and whenever you are giving out steroids, especially in younger patients, you want to look out for infection, which is a common complication, especially in younger patients with SLE, because you are giving steroids which are more like depressing the immune system, so look out for infections. Another thing to remember for these patients is you want their vaccines to be up to date. Remember that infection can lead to this whole cascade of events, so all necessary vaccines have to be up to date. The thing you're just going to note is that you are not giving any live vaccines to these patients. Again, it can lead to this whole cascade of events. And in cases where these patients had some arthritis, remember the MSS can be affected, NSAIDs are a good start. However, giving these, you need to be in mind with how long are you giving them. Remember some of the complications of NSAIDs. At the level of the stomach, you had a PUD, and at the level of the kidney, it led to renal dysfunction. And if these patients are having some sort of lupus nephritis, this needs to be in mind. So just to repeat on the treatment, hydroxychloroquine is something that you want. Steroids such as prednisolone, vaccines have to be up to date. Avoiding triggers is another thing, and NSAIDs for arthritis that can be noted. Alright, this has been the third video on SLE. Thank you for watching this video. Peace.